Very good. Well, welcome everyone. It's good to see everyone again. Those that we have on Zoom and those that are listening in, I think we are live now. Quick reminder to everybody, all of our members of the executive committee, we are trying to avoid the chat function during our meetings in order to be in compliant with the Open Meetings Act. Please, if you have a comment, raise your hand and I'll make sure I get to you and make sure that you're heard during the meeting. With that, let me start off and take the official roll. Let me start off with Dr. Goodman, Baylor College of Medicine.
I'm here this morning.
Very good. Dr. Williams.
She's out doing training.
Okay. Dr. Liberzon from Texas A&M. I think he's doing some traveling today and maybe in and out a little bit. Also from Texas A&M, Dr. Harper.
I'm here, and you're correct. Dr. Liberzon is traveling today.
Okay. From Texas Tech in Lubbock, Dr. Wakefield.
I'm here.
Very good. And Dr. Trevino.
I think she's giving a presentation today.
Okay. From Texas Tech, El Paso, Dr. Martin.
Yes, I'm here, and Dr. Thompson will not be here. He's on vacation, a real vacation, where he doesn't join every meeting.
Okay. All right. From University of North Texas Health Science Center, Dr. Podolwitz. Alan. And Dr. Farmer.
I'm here as well.
Very good. From Dell Medical School, Dr. Nemiroff.
I'm here.
And Dr. Strakowski.
Here, David.
Very good. From MD Anderson Cancer Center, Dr. Tan and Dr. Robert. From UTMB, Dr. Wagner.
Here.
And Dr. Vo.
Here.
Very good. From UT Health Science Center in Houston, Dr. Suarez. Haven't seen him yet. And Dr. Babatrope.
Present.
Very good. From San Antonio, Steve Plitzka, Dr. Plitzka.
Away today.
Okay. And Dr. Blader.
Here. Good morning, David.
Good morning. From UT RGV, Dr. Escamilla.
I'm here. Good morning.
Good morning, Michael. And Mr. Patriarca.
Good morning, here.
Very good. Good morning. From UT Health Science Center in Tyler, Dr. Bryant.
I believe she's in a training this morning as well.
Okay. And Ms. Nichols.
I'm here.
Very good. From UT Southwestern, Dr. Taminga.
Yep, I'm here, David. Thanks.
Good morning, Carol.
Morning.
And Dr. Ibrahim.
Good morning, I'm here.
Very good. From Health and Human Services Commission, Sonia Gaines. And then we have a vacant position at HHSC. Mike Maples has officially retired. And so we're waiting for the new nominee for that position. Then from the Higher Education Coordinating Board, Dr. Silverman. From a hospital system, Ms. Wesley. From Meadows Mental Health Policy Institute, Andy Keller.
I am here.
Very good. And from the Hogg Foundation, Octavia Martinez, Dr. Martinez.
Morning, David.
Good morning. From the Texas Council of Community Health Centers, Danette Castle.
I'm here.
Very good. Then I am here, and then Dr. Borges, James Borges. Okay, 1 second.
Dr. Borges is here.
What's that?
Dr. Borges is here.
Okay, Dr. Borges, are you here?
I am.
Okay, very good. So that puts me at 22. And so we have a quorum. If you're going to leave, if you could let me know beforehand, Again, so I can make sure that we have a quorum during the essential votes that we have today. So with that, we're going to juggle around the agenda a little bit based on some people's other activities they have to be in today. But we need to first approve the minutes from the last meeting. If they were sent out yesterday, if everyone could take a look at that, please.
Move to approve.
I have a motion to approve.
Second?
Second. Any further discussion? Hearing none, all in favor of approving the minutes from the last minute or meeting signify by saying aye.
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 Opposed, nay. Any abstentions? They have passed with a unanimous vote. What we're going to do now is we're going to jump to item 5, which is for the participating institutional agreements, and then move on. Andy, going to go to you then after that, and then on the budget, and then circle back around to items 3 and 4. So let's go to item 5, the information and updates from fiscal year 22-23 participating institutional agreements and closeout of the last biennium. And let me hand off to Lachelle.
Hi, good morning. So as we finish out this biennium, we have a couple of housekeeping items. First one will be development of lessons learned reports for the 4 main initiatives, TCHAD, CPN, CPWE, and CAP fellowships. That was part of the PDDs that were developed. Once you've completed this year's fiscal financials, we need a final expenditure report. Any funds that are not going to be expended or unencumbered will need to be transferred back to the coordinating board. You can't keep FY 22 or 21 funds into 22. Those go back to the coordinating board. PIA agreements for the next biennium are being drafted right now, waiting the outcome of today's budget vote. Once we get that in, I'll quickly put the numbers into the documents and then start circulating those, hopefully middle of next week. And that'll give you a chance to have a look at them. And if you do have any comments, let us know. David Lean, unfortunately, is going to be out of the office next week. But if there are any changes, we'll get those turned around pretty quick the week after.
Very good. Any questions for Lachelle related to closing out the last biennium and the participating institutional agreements? All right, hearing none, let's move on then to item 6. Before I do that, a couple of logistics things here. That we've had a couple of executive committee members that have joined us since I did roll call. And again, just want to make sure that we have their attendance here. Dr. Bryant, I believe you're here now. Is that correct?
Yes, I am. Just had a connection issue. Thank you.
Okay, I think a couple of people did. So thanks, Dr. Bryant. And then Dr. Trevino, I believe you're here also now, right?
Yes, sir. Good morning.
Good morning. Just want to make sure the record reflects that. So we're going to now jump into number 6 and number 7. And I think that in many ways, they're a little bit related. The number 6 has to do with the American Rescue Act and funds that are coming to the state that I think the state that are related to COVID and the impact of COVID on states across the nation, and want to make sure people are aware about this opportunity and have some discussion related to how they could be helpful to the work that we're doing. And Andy, I'm going to hand off to you and let you lead this conversation and share the information that you've gathered related to this opportunity. Andy?
Sure, David. Thanks. Yeah, thank you. And happy to do so. And just want to, I think this is something that we need everybody to be thinking about, because this is a pretty unprecedented opportunity and chance to respond to some pretty unprecedented needs. So the state, and it also, I think relates to some of the things we had hoped to do that, we certainly are thrilled to have the funds we do have from the legislature, but we know that the needs are tremendous and growing, particularly among children and families. So as part of the ARPA funds, the American Rescue Plan Act, funds went to a variety of places, state and local governments, schools, but the state itself has just under $16 billion that it's going to make decisions on later this year about how it wants to spend. And these funds, unlike some of the other COVID relief funds, actually have quite a long trajectory to be spent. So the costs need to be incurred no earlier than March 1st, 2021. So they're forward-looking funds. They need to be obligated by the end of 2024, and they need to be spent by the end of 2026. So, when we think about that runway for building and spending funds, it's not unlike what the horizon was for the district program under the 1115 waiver, 10 years ago, when we had an opportunity to build some infrastructure to respond to unmet needs and to ramp up in preparation for expansion of care for people who had uncompensated care. So this is really very, very different than the other relief funds where decisions had to be made, almost overnight. The money had to be spent in less than a year. This is actually several years. I mean, it could be as much as 5 years of spending almost if you plan it out the right way. Actually over 5 years. So, because it goes through the end of 2026. So there's going to be a special session, another special session, not the current special session that we're sort of having, but one in late September, early October, where the legislature will make decisions on how to spend all or a portion of the $16 billion. There's a lot of flexibility in how these funds are spent, but there are specific allowable uses that are spelled out, one of which is specific to mental health treatment. And it's not just mental health treatment, it's pretty broad, actually. It also talks about telephonic supports, crisis intervention, as well as evidence-based practices to address the social, emotional, and mental health needs of students. So while schools have their own funds to look at that, these funds that the state has also are allowable for that. The other thing I think is that the legislature has been pretty clear that it really wants to stick to the spirit of these funds and use them for expenses tied to COVID and not for ongoing stuff that would last, past 2026. So the idea is not to start new programs. The idea is not to create obligations after the funds are gone. The idea is really to respond to needs. And so, there's really no clearer need from our perspective, and of course we're biased, than the tremendously growing needs among children and families, which just, our projections, I think the projections of lots of other folks looking at this would say are going to increase. This is not the kind of thing where, the things go away and then, everybody goes back to normal. I mean, it hasn't actually gone away yet, but we expect there to be, as COVID continues to recede, which we expect it to, just like after, people return from war, just after a traumatic event like a hurricane, you're going to have more emotional needs unfold. And we're seeing those now. I mean, I think anecdotally, every emergency room that serves children has seen unprecedented numbers of adolescents coming in. Evidence suggests that's disproportionately falling on girls, young girls and young women, not disproportionately falling on communities of color. So there's a lot of need out there. So this is an opportunity, I think, for each of you all with the programs we have through the consortium, but also more broadly in your roles as partners within your local systems of care to identify needs and put plans forward. And we believe that there is a unique opportunity for the consortium as an entity that has won the trust of the legislature, that was invested in more in the last legislative session, to put forward a unified plan where really we move forward together and don't just let individual universities and medical schools address the needs in their community, but really back each other up. Because one of our biggest challenges during this time is workforce. I mean, there's a tremendous expansion of workforce. And I know many of you know that it's not just in the public sector. There's private startups that are offering people, hey, work from home, earn lots and lots of money. I'm sure you're seeing that among your faculty. So, and that's another thing, by the way, these could be used for. I mean, they could be used for, retention, additional spending, things that would help you keep people and help you recruit people. So, our sense is that's a long enough time frame that it creates a reasonable opportunity to expand, surge up, create what we're calling surge capacity, with the idea that that would then, over time, and I think through normal attrition and other things, it would be pretty reasonable over a 6-year period to not feel like what you would do over the next 2 or 3 years would be a tremendous risk. You could then wind down, in those latter years. So that's our hope. We also would love to be supportive of you in this from the Institute with planning information. But I think a lot of the information, because the schools you work with, the clinical institutions you work with are reporting more and more needs every day. So this is a pretty important opportunity. And I think it's a chance for y'all to step up yet again and do even more for the state. And I would hate to see these funds go to other things that just aren't as important. So that was an overview. David, were there other things I was supposed to mention, or did I?
No, I think that's a good lead in, and maybe we can open it up for some discussion, and then I want to think through with the group of kind of a systematic approach to make sure we position the consortium well related to putting potential items in front of the legislature. And so why don't we open it up? And Alex, I see your hand first, and then I'm going to go to Dr. Nimroff.
Thanks, Andy. Just a quick question. Do you have any kind of summary document on this act that you can share so we can have a little bit more detail on it? Number one, and number two, is there any indication of who's eligible to apply for this, or is it going to be determined by the legislator, as you mentioned, in late September or October?
Yeah, it's a great question. So yeah, we can send some information around. I mean, there are some fact sheets on the act that we've seen, and all these little facts are buried in various places, so we can sort of put a little summary on it. But we're happy to send that out after the meeting. I didn't bring anything prepared today though. But the other thing, Alex, is it's pretty bare bones. I mean, you can the state can do whatever it wants. And so in terms of it just has to fit within the broad parameters of responding to the intent of the act, which everything that the consortium does, including building additional training capacity to surge. I mean, all of that could be framed is part of an expansion of treatment capacity. So it's very broad, and the legislature will decide.
I think that last part, Alex, of the decisions, the legislature is going to decide how that $16 billion is used. Now, they may make a large application or apply a lot of money to HHSC or DSHS, and then there may be an application process. But the preliminary decision will be from the legislature, and they may decide individual projects that they will put money in. Okay. So let's go to Dr. Nemroff, and then Dr. Martin, and then Dr. Ishkamiya.
So COVID-19 is a neurotropic virus. And there's now a boatload of evidence that it directly affects the brain. And part of the reason why patients post-COVID have a remarkably large increase in both depression, other psychiatric disorders, but also because of their hospital experience, post-traumatic stress disorder. This has been documented in a large number of studies, and in my capacity in chairing an APA task force, we're compiling all this literature, and it's really frightening in terms of the neuropsychiatric sequelae of COVID-19. And we are going to need a workforce in order to treat these patients, how to treat them, both in terms of cognitive effects as well as affective disorder and trauma. So we really should be at the forefront, and this should be, I talked to David about this yesterday, it should involve not just children, but pregnant women who are terribly at risk, their offspring, and also obviously adults.
No, that's very good, Charlie. I think one of the things we're going to have to navigate is this is the Child Mental Health Care Consortium, but the legislature can direct us to do a variety of things. And to be transparent here, one of the things that we have talked about before in this forum, and one of the areas that we're trying to think through is the potential of pilot programs for perinatal mental health. And this may be an opportunity to move some of those things forward. I think there's going to be a lot of things related to child mental health, but we also, the legislature could direct us to do some other programs. We have all the academic institutions in the state here working together. And so there may be some of those opportunities that the legislature could direct us to do. Andy, I'm going to see your hand just so you can react to what I said.
Yeah,
and then go
thanks.
to Dr. Martin.
Thanks, David. I think that you're exactly right, Charlie. I think, look, this consortium came together and stood up and said, we're going to respond to the needs of our children after Hurricane Harvey and after Santa Fe and after there was sort of an awareness in 2019 around needing to do more. And so this is a similar opportunity. And I think from our perspective, we've kind of socialized this with some folks who I think would be deeply appreciative of similar leadership being shown. And I think putting out the full array of what this consortium can be together with its partners. It's us with our partners. It's not just, y'all, because you're really anchoring, local systems and with your LMHA partners, I think that creates additional bandwidth. So, if we had like a lane, like here's the things that we're doing now that can surge up. Here are new things we can start up and surge. I think if you do that, you have to be cognizant that it will ramp back down and you would expect things to move into other places because they don't want to start a new program. But I think, and then there's going to be things too that you may just want to do on your own. There may, schools you may be partnering with. We were talking to a county in the Valley who wants to start up a multi-systemic therapy team. There's things that may make sense for you to do individually, which is fine. But I think the more that can go through the lens of the consortium, it allows the legislature to see, I think it gives hope, right? It's not just a bunch of one-off things happening around the state, which are fine. It's also, our top people who we respect and depend on the most being able to step up in a moment of unprecedented need. So I do think expanding beyond just the core consortium should be our intent in terms of what we put out, but it'll just need to be laid out through the right vehicles because obviously the consortium is only authorized to do certain things and we'd have to fit that around those parameters, but I'm sure that can be worked out.
Very good. Dr. Martin? Sarah, did you have a comment?
Sorry, I was muted. You missed all the good stuff. See, I have all kinds of ideas. And so after I've been, not only am I division director here, but I'm actually doing all the CFAN stuff and all of the TCHET stuff and seeing the patients, talking to the doctors. And one thing I would love to do, and this might be a time that we would be able to add it, is the Massachusetts model has a one-time consultation clinic. And we've actually applied for some small grants to do that. I would love to do that. And if we don't get it through this, you all are always bringing us opportunities for other projects. So anybody who seems interested, we definitely want to start that. I think it's a way to get a lot of the a lot of the physician, primary care providers that are more hesitant about doing psychiatry with the phone consults. If we just added that one element, I think we get so many more people on board and so many more kids treated right away. And then I definitely think adding the adults. We know how to do this now. We have the infrastructure. We could get it up and running, an adult psychiatry consultation service just so quickly. And then I know a lot of places are talking about TCHAT extension services. So this is a way we could do, and if we could associate symptoms at all with COVID, this would be the perfect time to add on TCHAT extension. So those are the projects that we would be on board 100% if anyone else, anyone else wants to do it.
Very, very good. Dr. Escamilla?
Yeah. You've already addressed some of the things I was going to mention, but yeah, first, I do think expanding to adults would be really helpful. And I just wanted to suggest one mechanism for that might be the chairs meetings that we're having, where we're working on developing things that might be outside just the child consortium. So that's a mechanism you guys might think about. And then I think the other thing I was just interested, how do we put a proposal together for the consortium? What would the timeline be to get that together? And I think we should do something here. So just wanted to bring up what's the practical next steps.
No, Michael, I think that's a good question. What I would like to do is have this general conversation and then have that process conversation. Because I think we need to be organized, and there's several things about that I'd like to think through. But let's have the other comments, and then that's where I'm going to end up on this conversation, is the process. Does that make sense, Michael? Dr. Iskamia?
Yeah, it does. And just one last thing, what Andy mentioned, the maybe helping with retention of faculty, that is an issue we're really struggling with because of the pay differential in the private sector. So that could help us mobilize more faculty to work on this.
Dr. Martinez.
Thanks, David. Tremendous opportunity. I do want to sort of highlight that whatever we do, and actually whatever the legislature does, if we can influence and ensure that we're also doing all of these tremendous things, regardless from the clinical to, the external, that it's be done through a health equity lens. We've seen which communities disproportionately were affected. So we know this. I think behavioral science, especially psychiatry, we're in a unique place that we really can help the state of Texas and even the country how to move things forward. So I really want to emphasize that we do things with a health equity lens, but also thinking about the other structural drivers that we know that are influencing our community members and their health outcomes. So definitely where we can shore up and we need additional stand up, like in workforce and in our clinical settings, but thinking also, I think the potential of what should be done outside the four walls of the hospital and the four walls of the ambulatory setting, where we can ensure that we're having a holistic approach to developing what we all want, which is true continuity care and not a fragmented continuity of care that currently exists. So I just want to emphasize that. And to Charlie's point about this virus, I think it'd be important that we ensure we're also going to have a concerted effort against PASC, the post-acute sequelae COVID-19 syndrome. It's going to be disproportionately with communities of color because they're the ones getting hit the hardest. They're the ones that are being ill, but it's across the board. But also it's an amazing opportunity to help not only our colleagues, but even the general public truly understand the mind-body connection. So I think there's just some really amazing opportunities here. Thank you,
Very
David.
good. Andy, I'm going to go back to you.
Thanks, David. I think that, Octavia, there's a few, that's really important. Thank you for framing that. And I think there's some very specific intersections with our work. One of which is the research that shows that Black children were 50% more likely to lose a parent to COVID across the country. So I think that's an incredibly important statistic that we have to look at how it impacts and look at our communities and particularly the Black communities within our catchment areas and talk to them, to be partnering with leaders and say, hey, how can we respond? Because it's not going to necessarily, there may be other things we need to do to respond. The second thing is the statistic, and I haven't seen anything beyond the original reports where the Dallas Morning News this spring calculated mortality among working age Latino Texans. And mortality from COVID based on their computations, I haven't seen this from a public health source, but their data were pretty compelling, was 4 times. And so it's not just the disproportionate loss within COVID, but it was in working age adults who were Latino. So I think that there are very specific drivers hitting children and families that we can attend to within that lens you're talking about, Octavio, that are directly relevant to our work.
Thanks, Andy. Carol, let me go to you.
Great. Just a second. Good. I just wanted to say that one of the things that might be appropriate for this kind of thing, we've started in Dallas, and that is under the umbrella of early detection, early treatment. We're starting to go to to our local juvenile detention centers, and we've made arrangements to actually screen along with the detention centers the people in there, the people that are living there, housed there, and where there's obvious depression, where there's obvious psychosis, where there's obvious anxiety disorders, we can go along with the detention center to the judge and ask them to be released to treatment. If there are other people in other, I was going to actually bring this up as a possibility to do across the state of Texas for other people who have relationships with their local juvenile detention centers, and wonder if maybe Andy might want to make a comment about this too. It would be both for the funding to screen at the detention center and then to develop programs for the indigent. Plenty of programs for people with money, but for the indigent people.
So if I could just, Carol, to respond just for your question, I think that that's one where we may want to also consider partnerships. And I think if we can show too that we are doing this in synergy with other partners. So for example, counties have a lot of money. I mean, Dallas County, Dallas County and City, I think have over $1 billion through there, just in Dallas, with similar parameters on it. So I think, things that fall within the purview of other entities like juvenile probation and juvenile justice services, would be best to do. And so like we actually, and I'm happy to share this with anybody. We did an analysis for, like I said, for Hidalgo County, who was looking at using some of their county funds to expand multisystemic therapy. And multisystemic therapy is a very evidence-based model that Houston and El Paso have been implementing with district funds, and local county funds are now expanding, and Medicaid will be adding it in 2023 as an in lieu of service. So that's one where you would have a pathway to have other funds take over. So it allows you to basically surge up now in response. And we have seen, increase in, I would say, despair-driven youth offending that has a definite mental health component and a mental health pathway to make better. But that falls outside, I think, of the consortium's direct role. So I think they would have to be in that other lane that maybe happens through the chairs. But I think a concerted thing where there was a discussion with counties in your area about that, it is very effective. And if they're seeing surges in youth offenders, this would be youth who are charged with offenses, I should say. This would it works really, really well. And there's a sustainability pathway. And similar to some of the things Sarah was talking about, Dr. Martin, there's going to be a sustainability pathway in Medicaid for those as well. So like those consultations, Sarah, you talked about, with collaborative care being added to the state plan, collaborative care will pay for ongoing consultation capacity within primary clinics. So this would be a way. So I think for all of these, we can talk about how there's a surge that ramps up and then either goes back down or ties into ongoing funding streams that have already been contemplated and are already, within the purview of authorized programs.
Very good. Quick, I'm gonna go to Sarah to you for a second, but there's a chat message to everyone, so I need to read it. It says from Beverly Bryant that we'd be very interested in working with juvenile detention centers in our area. And Dr. Bobatrope says likewise. Again, would encourage folks to say things in the open meetings. If you make comments, I have to read them in order to be in compliant with the Open Meetings Act. Sarah, let me go to you.
We're both Sarah's.
No, Sarah Martin's hand was up first. Sorry.
I'll let you go second, I promise. Okay, let's see. So I've been talking with Jennifer Evans at Baylor about, and she actually brought it up to me. It was something I'd already been thinking about, but the Zero Suicide Project, we really haven't had any time funding to really dig into that, but it seems like an amazing project, and the LMHAs are starting to dig into that too. So this might be a good time for something like that. And then also definitely the juvenile detention. We already have a clinic there, and we do the forensic evals, which sometimes we can't, but because of conflicts, but we definitely have our relationship. So let us know if you do anything.
Very good. Dr. Wakefield.
Well, I was going to say the same thing, that we have a clinic at our juvenile detention center, our residential program here. And I think that even if we don't, I really like the idea of the sustainability model and recommendations of MST, and wondering if, even if we don't utilize funds for that, if there's a mechanism for us to come together as a consortium and give recommendations about what are the evidence-based practices for this population of kiddos. They were definitely overly affected by this pandemic with being out of school and then having parents who are more at risk and parents who are out of work and things like that. And so I think it's a very good use of our time, if not our funds. If there are other places to get funds from that make more sense, I think that's fantastic. But it is a good use of this consortium to talk about what we would recommend as the standards for these kiddos.
All right. Dr. Blader, go.
One of the major problems that we're going to be confronting as a society for years is the impact of the pandemic on lost developmental opportunities, educational opportunities, and so forth. And there's no question that behavioral science, developmental science, where around children and adolescents, has an enormous amount to contribute toward any broad effort to try to identify the specific lapses and remediate them. So, it's fine for me. Yeah, I mean, I could call school districts and try to do some ad hoc kind of thing, but I absolutely think that we as a consortium should be collaborating with TEA and TPS to come up with a broad scale plan to see what we can do to help this generation in terms of learning needs, in terms of social developmental needs, and the burden that rectifying those things, frankly, is going to impose on families. What's the best way to move forward so we don't end up with a lost generation, or if not a lost one, one where the inequities, pre-existing inequities, are going to cleave even deeper.
Okay, thanks, Joe. Dr. Wakefield, your hands are still up. Did you have something else to say?
Nope, sorry, I'll lower it.
Okay, and then Dr. Keller, Andy? Oh, you're muted,
I
sir.
gotta do the mute button. I know it takes a moment. I'm going to do the hand first because I didn't want you to tell me my hand was still up. So I put the hand down, I put the mute button up. Anyway, so Joe, that's such a good point. And I think we really need to think about that, because the schools have about $12 billion separate from the 16. And so most of that went directly to schools. TEA has some. TEA is just, TEA doesn't have a lot of planning bandwidth to begin with. And they have brought a group in, and they're trying to wrap their arms around it. They have the effective school framework, which includes social emotional pieces, and very much that delayed development thing, both in terms of educational delay, but also in terms of the developmental issues you're raising up, is part of that. So anybody who wants to know about that, our team is involved in that. I'm happy if we could do a little briefing on what they're doing. I do think it's going to be hard for them to have bandwidth to do more planning. So I think anything that we could bring to them that's sort of like a turnkey, that says, look, we got this, and we're happy to scale this up. Yeah. And I think we can work together. You have excellent connections, other people here working with them. Certainly everybody with the T-Chat link has some good sense about what's going on in their school. So I think if we brought something turnkey, it would be something where I think we could put it out there, and it could potentially be something that schools partnered on too. And the funding, it may not be that for example, the state may want to say, hey, we'll pay for half of this, and we would want a school district then to bring up the other half of its funds. I don't know exactly, but I mean, it's worth thinking about that, because we also want to make sure that we're cognizant in our planning of these other efforts. So so that I guess there's a briefing opportunity, but I think the thing I would suggest we do is take your ideas and the things we're discussing about, plus the T-Chat knowledge we have, and propose turnkey things like T-Chat's expansion. If we could add modules within T-Chat that did some of the things like extended T-Chat that would maybe T-Chat Lite, that would be more focused on social emotional. I think branching out from that and basically saying, look, we have a solution for you if you want to, partner on it, would probably be well received.
Absolutely. And many of the schools are, I'm sure they know as well as anybody that a lot of the enrichment or compensatory things that they have in mind, the more stress families are under, and the more underlying problems that there are, and the less traction those things are going to gain. So I think it's important that if we can, that we bring our expertise and our potential contributions to the table to work with them on ways to support families through this, meeting parental mental health needs where that's indicated, because it's going to fall a lot on families to make sure that that there's follow through with all the good compensatory intentions that educators have, for sure.
Very good, Joe. Let me go to Octavio, and then Dr. Wakefield, and then Dr. Wagner.
Thanks, David. Question for Andy. Good point, Andy, about the schools, especially in capacity. Are the dollars allowed to be used for capacity building as well, to really partner up with I love the idea about the turnkey approach?
Yeah, I think we'd have to frame it, Octavia, as sort of a time limited response. I mean, I think that there's very much sensitivity to, creating some new program. I mean, I think that everybody's very concerned about that. So I think surging within existing programs with a planned retreat, or surging in ways where there would be sustainability foreseen, like some of these things that Medicaid will pay for, I think are the two paths. And I think too, while we do need to be, this is an opportunity for us to come with a range of solutions, we do need to be cognizant that, of course, the ones that are within the existing lanes we have are going to be best received. I mean, that for sure, because there's going to be less fear that we're doing something new, that's truly a surge. So where we branch out, we just need to be very thoughtful about how we're not going to convey that the legislature somehow created now. I mean, we could conceivably ask for $500 million, right? I mean, if we had the workforce to do it, and I think the needs are there. We just have to be clear that we're not planning on having $500 million in ongoing funding going to the consortium or other sources, because that would be a non-starter.
Yeah, good point. Thank you, Andy.
Dr. Wakefield?
I just wanted to mention, and maybe have Dr. Trivedi talk a little bit about, or just be on his radar about their school programming for mental health and suicide prevention in schools through UT Southwestern. We've done some through the Teach Ed initiative, to what Dr. Keller was saying. We've utilized some of our infrastructure to deliver some of this additional programming to schools. And I think we'd be able to do that very easily with some of his evidence-based initiatives. Dr. Trivedi, would you mind talking about that just a bit?
I'm happy to answer any questions, but I think it has been a collaboration with the local school districts over the last 4 years. We've reached about 20,000 students in these schools. And Dr. Wakefield's team actually is one of the teams that came. We have the trainer model. And so we do ongoing trainings for people in their school districts. They come there. It's a fairly rigorous certification process, but then they go in and they deliver this evidence-based suicide and depression prevention program that's been evidence-based as publications in Lancet, et cetera. And we now have extensive experience with this, so I'm happy to talk to anybody. I know Dr. Martin has also shown interest in the past, and we're gradually building it based on resources, but at least the first cohort from Lubbock did come last month, and we've been meeting with them, and they are going to disseminate this into their entire school districts. So I think this is one way of blanketing all students across, because one of the things that, as we all know, is waiting for the crisis or waiting for a diagnosis is often too late, and this is preventing it. So that's sort of the beauty of it. And we've shown, and they have shown, reduction in depression and suicide with this. So in some ways, it is actually, in my humble opinion, even a bigger impact than what we're doing with the consortium.
Dr. Keller, Andy, you want to react?
Yeah, I just want to say that I think that's a great idea, Sarah, and Madhukar, that program is fantastic. I think also in this sort of suicide prevention lane, Madhukar and I were fortunate enough to be awarded this Lone Star Prize from Lyda Hill, which is $10 million over the next 5 years, to help health systems ramp up collaborative care and measurement-based care, specifically around suicide reduction. And part of that plan is to, over the next 5 years, to engage different partners in the, not specifically in the consortium, but many of you. So Dr. Wakefield, Charlie actually, and Dell is sort of who we're working with in year one. We're hoping to expand that out to Dr. Wakefield and Texas Tech, and potentially other partners in year two. But one of the things that has been really helpful in our North Texas work that Maduka and I have been doing for the last few years are these one-time grants to health systems to implement collaborative care and to implement the IT changes to do measurement-based care. So they're doing universal screening and detection for suicide, depression, anxiety, substance use, and then ongoing monitoring of symptoms within primary care, which takes some electronic health record changes. Those grants have been about, well, they've been about $150,000 to $250,000 each, and they're one-time grants to help health systems like a hospital system and its primary care clinics make those conversions over. And it's not just happening. So far, Dallas Methodist, Baylor Scott and White are both doing that and are receiving grants under this, not the Lone Star Depression Challenge, but the North Texas portion, which the Meadows Foundation has funded. So that's another thing to think about. If you have health systems that you think in the next 4 years could do those one-time expansion kinds of things to help them ramp that up, that would be a use. The last thing on that is we've partnered with Vikram Patel at the Harvard School of Global Medicine and Social Medicine. And Vikram has this technology-enabled community health worker program that basically you train community health workers to be able to be workforce extenders, particularly in underserved communities, minority communities, other communities where primary care linkages may not be robust. Again, there's one-time expenses there to train that could plug in. And we may, Maduka, want to think about maybe doing like a separate thing, because this, David, would probably be something more that happens through the chairs process, because it would be outside that. But in that lane, there is a plan in place where you could just, if you had 3 health systems in your region, we could plug and play in terms of just, adding them in. And it's not a lot of money when you've got $16 billion. So just, that would be another way to potentially amp up some of your partners' capacity, which then would spill over into potential synergy with CPAN and the broader things that we're doing. So just think about that too.
Very good. Dr. Wagner.
So thinking about this in terms of the projects that we're currently doing and trying to not expand too far out of it, we really could think about something that specifically targets children that have been traumatized by COVID in their lives. Because in the schools right now, we're just saying if a child has some sort of mental health problem, but very targeted to that group. And then we could actually, if we had the money, provide interventions, evidence-based treatment for children that have been traumatized by COVID in their life. They're short-term, they're narrow. We don't refer them out elsewhere like we do in our other model, but we take care of the problem. And then we also include parents in the schools with education about COVID. If parents have to be seen to address some of the issues, because we're not at all dealing with parents right now, except that they bring their children in. So I think if it's very targeted towards, they want something that is that hopefully we don't have to sustain. And the hope is that we address whatever experience that happened to a child that's been affected in their entire, anything about their life in COVID, get it addressed, get it treated, include the parents. That could add to the program. And we've all got the infrastructure, but we just need more people and more money.
Okay, very good. Carol? And I saw Andy gave you a big thumbs up, Karen, so obviously in agreement. So then, Dr. Kaminga?
Yes, I know that there's a timeline to this, David, and I wonder if you or Andy can just review with us again. I know that we have to submit ideas somewhere within a timeline.
Yeah. So I think that's the next part of this conversation. Let me go to Danette Castle, and then let's go into kind of the process conversation. Danette?
So I didn't nod as vigorously as Andy did or as quickly, but I felt it in my heart. And so I wanted to just say to Karen Wagner's idea, I really support that in terms of focusing on young people, children who have been traumatized by COVID, because so many have been traumatized by COVID. And it's not just about losing family members. It's about loss of the relationships and the school challenges. And it's really broad. And for many of those children, they may not be eligible for the services that we're funded to provide directly. We are reaching out in some places to those kids with other sources of funds and support. Certainly some of the new funds coming in, we anticipate having a greater reach on that, but I really like the idea of that focus, and I just wanted to support it.
Very good. All right, so let's think about process. And again, it's a, you know, I can't lay out in front of you right now exactly how this is going to happen because there's a lot of things going on related to special sessions, you know, and when the legislature will discuss this. But I think, you know, it's going to happen relatively quick, meaning this fall, that they're going to need to have a special session to decide how do they use that $16 billion. And again, the feedback that I've gotten from the legislature is that they're looking for good ideas. You know, they want to be good stewards of these dollars. They want to make a difference. They want to make, they realize and have shown that they realize the burden of mental health issues in kids and adults here in the state of Texas by their investments, such as in this consortium. I also know that some of your institutions may be, you know, have their own strategy, and we don't want to get in the way of your own institution's strategy. I would also add, though, that a lot of times mental health issues sometimes don't get the priority when they are prioritized with everything else from a large institution. And it does seem to me that there's power in collaboration and working together and trying to do things similarly across the state of Texas. I think that's one of the things that the legislature likes, is that they can say, we're doing this together. And I have learned from working with this group over the last several years that, you know, that little motto of, you know, of quality improvement, that you share seamlessly and still shamelessly good ideas. This group does that. And as we have gone through for the last 2 years, as one institution is doing something good, it's being shared, people are talking to each other and developing programs together, and that drives, I think, quality improvement in these programs. And so I think there's value of us doing something consortium-wide. Now, exactly what that's going to be, I think there's been a lot of good things that have been laid out here just a little bit ago. Some of those have to do with things that we're currently doing and developing them a little further, or looking at some of these gaps. Everyone's been frustrated, I think, related to, you know, what happens after 4 TCHATS visits, and what are those opportunities, or the other things that have been laid out here. And so I think we need to put our thoughts together relatively quickly. I think probably the way to do this is, Andy, you know, if there's a document that can be shared widely with this group, let's share that document. I think then probably having you go and think through this, what are some of those opportunities? Again, you guys are much smarter related to these opportunities in your part of the community of the state of Texas than we are here. We need to hear from you what you think are some of those opportunities, but let's try to put that together in a relatively short time period, and then start refining it, and then vetting it, and getting feedback on it. And again, I think that will be well received from the lead. And so again, stepwise, if we can share a document with some details, you think through what are some of those opportunities. I would ask you to, I will have our team send something to you in a formal way to gather those thoughts. And then we'll start putting some meat on the bone, so to speak, related to what this could potentially look like, and get feedback from the legislature of what they would be interested in, where they see our role as a consortium, what they would see as the chairs of psychiatry group, what are some of the roles there that they could play, and get something to the legislature. I think we probably need to have something to the legislature by mid-September to be really competitive in this process. And the sooner we can get something in front of them, I think that the better position we will be as a consortium as a whole to be able to address these issues. Andy, does that sound like a reasonable kind of thought process and process here?
Yeah, I do. I think that we probably need to then maybe talk about a couple milestones over the next 6 weeks. Within that, I think, the document we're going to send out isn't going to say much more than what I already said, because there isn't that much guidance. So I think some time by which, if David, if your team's able to take, input, I think the ideas that were discussed today, certainly we have for the record, and we can sort of begin to sketch out, whoever can sketch out a frame. And I do think it needs to be framed with stuff we're doing now, mild, more of what we're doing now, mild expansion type things, reasonable expansions of what we're doing now, and then additional ideas. Something like that. I mean, those might not have to be the right frame. So I think if we don't have that within 2 or 3 weeks, and then it needs to be compiled, and then I think it needs to be put in front of folks so we can formally act on it. So I do think, do you have thoughts on those specific milestones?
Yeah, I think, again, I think our folks can start putting some of that together. Yeah, I think some of your folks could be helpful in that process. Again, I think folks can send something out to this group and start soliciting ideas and kind of start harvesting those ideas by mid-August. I think it's going to take us to late August to really delve into, just knowing my schedule and some of the other things that are coming up, that'll probably be late August before I can start refining that, and then have some high-level ideas and some meat on the bone, so to speak, with what it would take to do this, resources, funding levels at a high level mid-September, and then start getting feedback from the legislature. Again, this is something we're going to need to work very closely with the legislature to make sure that we're doing what they think we can do and what they think would be an appropriate role for the consortium.
David, this is Alan.
Yes.
I want to make sure we comply by all of the Open Meetings Act. So as we communicate, is it through you, or do we communicate through you, Andy? So that I know where communication needs to go.
Yeah, I am going to have Luann Southern from my team send something out to folks, and we'll do it in a way that if you reply, you don't copy all to the executive committee, so that we will follow the open meetings, and then you will provide us information. We'll try to put that together in a reasonable way. We'll work very closely with Andy, but I think that'd probably for us be the best kind of point person, having Luann Southern be that point person, and then we'll work as our team to try to work through this. Does that make sense, Alan?
Yep, perfect.
And David, let me just affirm that our role is to support the consortium. It's not to do anything independent. So I think any support we would do on planning would be support to Luann, just like you all would, and Luann's team. I do, in addition to that, if any school wants to brainstorm about stuff, I mean, we're happy to because we do have some planning data of our own that we're happy to share. So if anybody wants to, brainstorm together, we can do that separately. But I think the input needs to come from you all to Luann, and our role on the committee would be supporting the consortium's efforts, not anything independent.
And to be clear here, so I don't freak Luann totally out right now. That didn't mean that she was doing all the work and putting this together. It's just how we communicate to the group and how we can pull information from you, and then we'll have other folks that'll help put that together. But Luann, I see you've taken yourself off.
Yeah. I wasn't freaked out. Actually, this is really exciting. But what I did want to say is that Meadows and myself, and Lachelle, a group of us, I think Monday, if we can meet on Monday, that will be really good. And we'll just get it started then, developing a framework, gathering information from all of you, and we'll go from there. So.
Very good. I've seen that Sonia Gaines has joined us. Again, for the record, want to make sure that we've identified that she's here and part of this conversation. And Sonia, would love for you guys to be part of this as we put these thoughts together. Again, want to make sure that we're not duplicating what you are doing or doing something that would contradict the work that HHSC is trying to do.
Sure, happy to help and get involved. And I appreciate your comment about making sure that we're not duplicating, but definitely this is something that's needed.
Okay, very good. All right, thanks, Andy. I think that was a good conversation and good opportunity, and let's sort through that. So the next item that we have is the budget, and again, I think it does link to the previous conversation as we go through items. But yeah, I have a presentation I'm going to walk through. I again would first start off by thanking everyone for all the help in putting the budget together. There have been numerous conversations between us and your institutions as we have tried to make sure we understand the issues, the concerns, and put together a holistic package for the budget for the consortium as a whole. So thank you. If Michelle, if you or Luann could, start the slideshow. We did send out the budget last night to everyone. It has taken us a while. We have been moving as quick as we can, and part of the reasons we're trying to move quickly is because many of you, your institutions, need to take your budget to the Board of Regents and get their formal approval. And so my goal today is to come out of this meeting with the approved budget for the consortium as a whole, so you know your funding levels, so you can take it to your Board of Regents or whoever you need to for approval. So let me walk through the budget. This may seem digging into details, but I want to make sure everyone understands kind of the process, the items that we were able to fund, the items that we weren't able to fully fund, kind of the rationale behind that, and where we ended up. So let me start off with the budgetary process to remind all of us that last year, we asked every institution, what do you need in order to stay at steady state? And you provide us that information, and that amount totaled up to $118.5 million that was requested by the consortium. And we put it all into our ask. And again, a huge thank you to the Texas legislature for fully funding the consortium at that level, at the 118.5, which was the number we needed from the information we had gathered to keep each institution at their steady state. So following the legislature, we are a learning entity, and we looked at what is working well and where are there opportunities for efficiencies. And through that process, and we'll go through that, there were some opportunities to be more efficient in a couple of programs by the way that we were staffing some programs. And some institutions, we went program by program and looked at institutions were there opportunities to free up some dollars for us to make sure that we are the best stewards possible of those funds. And you identified $7.7 million that could be redistributed based on priorities for the consortium as a whole. We also asked every institution, again, with an additional year's worth of experience, what are the opportunities to, and hold on one second, I have a message to all panelists. It looks like Steve Stokowski needs to leave. And so just going to make, again, in compliance with the Open Meetings Act, make sure that he knows that everyone knows that he is now stepping out of this meeting. So we asked all institutions to identify opportunities to expand. Also, as they looked at their current budget, if there were some additional needs they needed in order to, now with a year's experience, to keep those service levels where they needed to be, what those items would be, but also what are some of those opportunities to expand. And just short of $17 million of opportunities to expand were identified. And so we have a little short of $8 million of funds that were available for reallocation and about $18 million of ask. And so again, we've had numerous meetings with institutions over the last month. Some of those items we were able to figure out how do you fund them right now through dollars that would potentially lapse and encumber the dollars to fund those items. But then we've been working, again, systematically to try to identify what we can do over the next biennium that we may not have been able to do from the previous allocation of dollars. So let's go to the next slide. A little bit about the process. Most of the dollars that were freed up were under the TChat bucket of work. And so we have made those TChat requests the highest priority. We also looked at how, if we reallocated dollars, we could increase service levels, and those were priorities. One of the boundaries that we've had as we've looked at developing the budget is I didn't want to change any funding line from the legislature by more than 10%. If I move dollars in any budget line more than 10%, either up or down, we need to go to the legislature and get their approval. Your institutions really need to move forward now related to this. And so we kept in place that 10% boundary and are below that 10% in any budgetary line changes for the consortium as a whole. I wanted to note that all HRIs that requested funding received at least part. Again, we weren't able to meet all your requests, but and we've had these conversations with institutions. I think we hit your most prioritized issues and we're able to get those addressed. We did look at current performance. There were some institutions that thought they could grow quite a bit, but they're also currently ramping up programs, and some of those further growth considerations were put off for the future as some of these other programs are developed. And then we tried to steer away from pilots. Again, we wanted to make sure that what we were doing was very consistent with what the legislature believed they were funding coming out of the session. So if we can go to the next slide, and this is the very high level program summary. And I'll go through the numbers and then go through kind of on the pie graph. But again, there were efficiencies that were developed, and one of those was in TChat. And basically the efficiency that was identified was that one of the institutions believed that they needed to have additional personnel out in schools. As they've looked at their model, they really didn't need to have those personnel out in schools, in those schools. And so that freed up a significant amount of dollars, as other efficiencies did. Again, if you look at the approval, I'm gonna go to the green column there and the percent change. There's a slight reduction in CPAN. We were able to put most of these dollars back into TChat, and so there's only about a 1% reduction in the total funding going to TChat. There were several opportunities that were identified for CPWE. That's the work for those that are listening that aren't an executive committee member, but those are the work with our local mental health authorities. That seems to really be effective and is a great opportunity for our residents. Seems to have value for the local mental health authorities, and there's an increased demand for that. And so we have put more money into that program and additional money to recruit and retain new child and adolescent fellowship or fellows here in the state of Texas. At the before I get to the very bottom, we kept funding for basically administrative things exactly the same. And so didn't put any additional dollars into the centralizing operating support hub or the external evaluation or into UT system administration. We did put an additional $600,000 of that $7.7 million that was identified into a way to help support research. And this will go to help our institutions recruit individuals. These dollars actually go to the individuals that are recruited versus to the institutions related to themselves. And I'll talk a little bit more about that in a second. So funding total is at 118.5. And again, you can see that 42% of the dollars went into TChat, 25% went back into CPAN, about 13% into CPWE, and you can see the rest of those, and I won't read those for you. Why don't we go to the next slide? So this slide shows the changes by health-related institutions. And so let me start off in the middle of the Excel spreadsheet there. And you can see where the reductions took place. And so Dell Medical School, in their initial base budget, they reduced it down to 3.4. by 3.4% as they saw, looked at efficiencies. UNT 0.1%. UT Health Science Center Houston, the base budget went down 37%. Now additional dollars are going to be added back into that, and I'll get to that in a second. UTMB, as they looked at efficiencies, reduced a program that resulted in about 4.5% reduction in their base. UTRGV by 3.5%, and UT Southwestern by 9.1%. And so that reduced in total that initial budget by 7.4%. But then again, we put the money then back in, and based on that process, you have the final allocations there in the green column, and you can see the total change. And basically what has happened is the institutions that were funded at a higher level have come down, and the institutions that were funded at a lower level have come up. And so the differences between institutions has narrowed significantly with this new budget. Again, going through here, Baylor College of Medicine's budget goes up 4.5%, Dell about 7%, A&M about 16%, Texas Tech, Health Science Center, and Lubbock is at the 3.7%. Sorry, sometimes hard to look across those numbers. El Paso 2.7%, UNT 7.4%. UT Health Houston, again, that's where the major change in TChat and model and efficiencies, and a big thank you to them for looking at that and freeing up these dollars so we can do these other items. But their budget actually comes down 33%. San Antonio goes up 12%. Tyler, again, was one of our lower funded entities. It goes up 16.8%. UTMB 7%. UTRGV. Again, thank you, Dr. Escamilla, for looking and taking that sharpened pencil to your budget and freeing up those dollars and those efficiencies. That is extremely helpful. And UT Southwestern overall comes down to 5.6%. And so again, the highest funded entities have come down, the lower funded entities have come up, and the differences between institutions has narrowed. And you can see that then in the pie chart. So let me go then to the next slide. And again, there was, we've been able to put in $7.7 million, but that leaves $8.8 million of requests that we weren't able to meet. This slide shows that by institution. Again, you can see that everyone that asked for some funds were able to get a portion of those dollars allocated to them. Some institutions saw, Texas Tech, El Paso, and I'll go through this in a little bit. Their request was much smaller than other institutions, and so on some of those smaller ones, it was easier to fully fund those. For some of the larger requests, we could get partial funding. Texas A&M University, the reason that that potential growth is as high as it is at $6 million is because we asked them, what can you potentially do in the community? Where are there opportunities for schools, et cetera? And they've identified a large number of schools that would like to have TChat if resources were put in place. We can't fund all of those at this time, but Andy, I think this plays into that conversation we had just a minute ago of the importance of these new dollars, is that institutions are identifying those additional schools that would like to have just basic TChat in the future. And we're already starting to identify those opportunities. Andy, I saw your hand go up. Did you want to say anything on that?
I was trying to put a thumbs up and I hit the wrong thing. So yes,
Okay.
just thumbs up.
Very, very good. So again, a big thank you to the institutions for looking at the budgets, where possible, freeing up the dollars, also looking at their communities about what the opportunities could be, and then working with us as we've been able to at least partially fund those additional asks. So again, in order to be transparent, let me go through what the requests were, what that we funded and what we didn't fund. This item, this slide has the TChat items that were requested and that we're going to propose for approval. It totals $4.4 million. Walking through this, Baylor College of Medicine has started a Step Cares initiative They requested $607,000. We were able, working with them, we're able to identify that if we put in $400,000 right now, we would keep them at a reasonable level of service. And we feel good about putting those dollars in. With Dell, a couple of things they're going to do in order to significantly increase service levels. They have put investments in technology, and they believe that that's going to increase them being able to serve an additional 25%. But then with these additional funds that we're going to put in, they believe that it'll result in about a 30% increase in service delivery over the next biennium. And so, you know, because of that, we put in the $400 and basically $50,000. Texas A&M, again, has identified significant opportunities in their community. We can't fully fund those right now, but wanted to do partial funding of that and put in $900,000. For Texas Tech Health Science Center, they expect to expand to 40 additional districts, cover 59,000 additional lives. And with that investment of $275,000, $274,600, it'll result in bringing those additional districts online. For the University of North Texas Health Science Center, they have noted a significant increased demand in their workload with some of their urban school districts and thus need some additional dollars. And we were able to fully fund that at $607,826. For San Antonio, again, opportunities to expand TChat into some additional schools and provide services to about 504 unique individuals, people that are referred to them. And so we weren't able to get them the full funding, but about 80% of the funding. So we put in $859,000 into that initiative. For Tyler, they are looking to expand to some additional schools. Again, another one of our institutions that identified many schools that they could expand to in a rural area. We can't reach that funding request right now of the 1 million, but for some additional, but we're able to put in $130,000 to meet some of the training, marketing, and things that they need to do to drive up some of that demand. And again, I think, you know, that other $900,000 goes basically into that column of projects that we know are already ready to go and schools that are asking for these services, and will be part of that additional conversation we just had. And then UTMB, they've identified additional school districts, 11 school districts that would serve about 53,000 covered lives. We weren't able to get them all the funds they requested, but about 90% of the funds that they requested, which will move them forward on that path. So if we go to the next slide for CPAN, the one request that we received was from UT Health Science Center in San Antonio, that they needed some additional help on coordinating the research and their outreach efforts, and to increase their utilization, and asked for $195,000, and we put those dollars in. If we go to the next slide with CPWE, Dell Medical School has not been able to do CPWE yet, as they have developed their program. They concentrated on the other programs first as they're building their medical school and from the ground up. Now, a year later, they have seen an opportunity and a willingness of their local mental health authority to partner with them. And they requested $542,000 to do that. Because of that limit that I have related to moving funds more than 10%, I can't fully fund that right now, but we're going to put in basically $390,000 into that to establish that relationship for CPWE at Dell Medical School and Integral Care here in Austin. For El Paso, they want to expand rotation sites and additional time in the local mental health authorities they're currently working with. And so we put in $144,710 into that initiative. UT Health Houston has identified another local mental health authority that wants to work with them, the Burke Mental Health Center. We believe that's a great opportunity, and so we're putting dollars in for that initiative. And then in Tyler, There is a rural institution, local mental health authority in Pittsburgh, Lakes Regional, and that is part of their expansion of CPW. And so we were able to put funds into that initiative to allow for that expansion. And so again, significant, I think, success and being that this CPW is being very, very well received by our partners. And so continuing to move those programs forward. And then under CAP fellowships for Texas Tech, a small amount of money was needed in order to keep everything basically at steady state. For Tyler, in order for them to have the other support that other institutions are receiving for their fellowships, additional dollars needed to be put in. And UT Southwestern wanted to add an additional fellow, and so those dollars were put in for that expansion of their fellowship training program. Again, for the long term, those will be very important. So again, in order to be transparent, the things that we didn't fund that were requested, Dell had identified what sounds like a really great opportunity to have integration into their electronic medical record for consultations for CPAN with their psychiatrists and primary care providers. We just couldn't do that this time. That doesn't mean we don't think it's a good opportunity, but that may be something that we can work on in the future. For Tyler, looking at expanding a CPAN, we can't do that right now. But again, as their program CPAN ramps up, that will be a funding opportunity. For UTMB, they had a request, but we were able to meet that request in another way. And then for UT Health Science Center, San Antonio under CPW, there was a pilot. We can't fund that right now. Again, part of that issue is that cap that we receive, that we have related to transferring 10%. So let me go to the next slide. Related to the research initiative, after a lot of thought and looking at the challenges that the hubs were having and the nodes were having, I thought that it would be in the best interest of everyone to use $600,000 to be used to reimburse first individuals that are coming in to be part of these research projects. And so all HRIs, as part of their base budget, are responsible for paying the cost of 4 participants a month. What these additional dollars would be used for is for institutions that exceed that level on a quarterly basis, that we will have a methodology to help reimburse them for the dollars that they're giving to those individuals that are participating in these research projects. We'll do that on a quarterly basis, and we'll share the full methodology at a later time. But for budgetary purposes, we want to put in that $600,000 into that initiative. So this is the budget for the research component. It is aligned with the decisions that were made last time, that 40% of the dollars would be used for hubs, 60% of the dollars would be used for nodes, that all institutions would be able to participate, and they, for both years and for both projects, the funding that they would receive is $500,000. And so that is, again, consistent with the decisions that were made at the last meeting. With that, that's my last slide, and I'm happy to answer any questions that the executive committee has related to the budget. And again, that was sent out last night, and I hope you've had a chance to take a look at it.
Your team has done a marvelous job in, all across all the hubs, all the HRIs, the work you had to do. I mean, finagling budgets through 13 different HRIs is probably one of the worst nightmares I can imagine in my life, trying to figure out how to get each and every one of those to agree to something. And I think the budget, it looks great. I think it's doable. I don't think there are things out there that we cannot perform on, which I think back to, Andy's point earlier, is that because we've shown that we can perform, we need to be able to step up and say, we can take on another challenge.
Very good. Octavio, I see your hand.
Agree with the comments and just want to say, David, really just to stand up the patient incentives component. So just want to really thank everyone for that, for including that. I think it's really integral and important in the work we do. And really, again, just talking about a health equity lens. And excited to see that'll be available for all of the hubs.
Thank you. Dr. Tominga?
Yes, I just wanted to agree with Al and David. This process, even though there's more people than can fit on one Zoom screen, you and your team have been able to reach us all and enlist us in cooperation and enlist us in a final product. And it's just, I think it's just magical, and I can't think of anybody else who could do it. Thanks.
Well, I want to be very clear here. I'm presenting the budget, but Lachelle and Luann and Nagla and the team are the ones that have been doing all the tough work, and my role is to present. And so if there's any credit, it goes to those folks.
So you're just arm candy?
I haven't had anybody describe me like that for a long time.
Okay.
Okay, Joe?
All right, David, we know who did the hard work. Many congrats to Lachelle and company. It's really the information that was sent around is just extraordinary, extraordinarily well put together. It's wonderful. Small technical thing in your final slide there, to the extent that this is that this will become a public document, I would suggest changing patient incentives to participant.
Very good. Good point. Thank you, Joe. Very good. Dr. Escamilla?
Yeah, just great job on everything there. Just a question of clarification, and maybe this will be in the research networks, but did I understand that in our budgets, we should budget for 4 participants a month, the subject fees or the participant fees, and anything above that will come from this other source. Is that correct?
That is correct.
The only caveat to that is any of the patients that were enrolled in the previous biennium that you have an ongoing obligation to, those also need to be budgeted for.
Okay, that's very helpful, because that helps us to move some funds to research assistance that makes it more possible for us to do the work.
I think putting those dollars there, and we'll do it in a transparent way here, makes it fair for the high recruiting entities, but also the smaller entities that need that additional support. And so we believe that this is a good solution to that.
So David, do you need a motion to approve the budget?
I need a motion to approve the full budget.
I motion to approve the budget.
I have a motion by, who was the second?
Dr. Bryant seconds.
Dr. Bryant has second. Any further discussion? Hearing none, all in favor of approving this budget, signify by saying aye.
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 Okay. Anyone that's opposed, signify by saying nay. I hear none. If anyone is abstaining, please identify that you're abstaining. All right, very good. I think we will let the record show that we had unanimous approval of the budget. And again, the credit goes to all the folks that are here. And again, thank you again for the folks that delved into their budget with a sharp pencil and figured out where there were some cost savings, and be willing to share that across systems. Again, that doesn't necessarily happen a lot. And so thank you for being willing to do that. Thank you for identifying opportunities in your communities. Again, we will catalog those and then have that as part of this next conversation we're having. And again, huge thank you. Special Lachelle has been into the numbers, digging, doing the spreadsheets again with the rest of the team. But I really appreciate all that support. Dr. Sarah Wakefield, I see your hand.
I just have a touchy-feely comment that I wanted to reflect on 2 years ago when we were in the same position and we were all in a room together on the UT campus, and there were cheers and claps, and we were so excited. And I think we could not have known what actually lay before us. We thought it was a big enough deal that we were going to roll out all of these projects. And we couldn't have known that the pandemic was before us as it was. But I am so proud to be a part of this consortium, and I think we've done phenomenal work. And I wish we're all together cheering and clapping today, but I am cheering and clapping here in Lubbock, and I'm really, really excited to continue this work with you all.
Very nice. Thank you, Sarah. All right. With that, we will move forward in our conversation. Let's jump back to number 3. Alex, Dr. Plitzka can't be here today. I guess quick question for you. Do you want to go through item number 3, or do you want to wait for a subsequent meeting, or do you feel comfortable with presenting that information today?
Dr. Pliska asked us to go ahead and move forward with this.
Okay.
It's an important agenda item. So do you want me to just dive into it?
Okay.
So essentially what the topic on hand now is the approval, review and approval of the Data Governance and Management Committee charter, which was sent out to everybody here on the executive committee, I think at least a couple of weeks ago. And that was following a preliminary discussion of it at our last EC meeting. Since our last EC meeting, we actually have had an increase in the number of participants at this particular governance committee with folks representing all HRIs. And then we, from there, we worked on the document together. So every one of your representatives helped contributed to this revised charter that was sent out to you. I think the charter actually has track changes in it, so that's transparent for you to see what we did. The main goal of this charter is to outline the responsibilities and the task ahead for the Data Governance Committee. And then the main thing is to remind the folks that this particular committee will act as an advisory to the overall executive committee, which is us. I hope that folks had a chance to review it. We've made changes based on the feedback that we had during the last meeting. And I think the bulk of it is pretty much agreed upon by everybody. I think there was one outstanding item that was kind of up for discussion, was the review of publications. So I want to open that up to the floor for people to give feedback on if they had a chance to review the document. Dr. Martin?
Yes, I just wanted to point out that in the discussion of the data governance working group or committee or whatever, I've forgotten the exact name of it. It changed recently, but everyone knows what I'm talking about. I had actually presented something for an approval. And so then that led to a discussion, and mine was it's an abstract that I submitted to ACAP, and we're going to do with some other universities in Canada and the United States. We're going to talk about the consortium and the projects we do, and they're going to talk about their own state projects or province projects. And so that led to a discussion that it's really the data that's going to be looked at, not description so much, so that when you're submitting something for approval, they're just going to check to make sure the numbers are matching what the data we have collected as a state, maybe through Kosh or through Dr. Lakey and Luann and Lachelle and Nagala's numbers, but not other stuff as much, if that makes people feel more comfortable. I thought people might feel more comfortable if they knew kind of what the discussion was around getting that particular thing approved. And it's just an abstract now. So if anybody also wants to send me any recommendations about things I should definitely include about our projects over the last few years, send me an email.
Thank
So
you,
Sarah,
Dr.
it wasn't painful. It wasn't painful to go through the process, and it made sense.
Right. Exactly. It was very, very, very quick too.
Thank you, Dr. Martin, for that. I think the rationale for us to look at the data is because on section 10, we believe that since this is a shared funding source with the Texas legislator, any data that's generated from the use of these funds through the consortium are deemed to be owned by TM to the consortium. So it makes sense that, when you guys present data, that we just check to make sure that it's congruent with what our other collected sources are reporting as well. There is a mechanism that if any individual HRIs are, are denied or or suggested to be revised or anything like that with regard to their data, they can take it up to the EC, the large EC group, which is this group, and then make an appeal for approval to go out. And so it's not like we are the end all be all of this review process. It's more of an advisory capacity. So we have been doing a lot of data work with Kosh and Trek. And so we would like to have this charter approved so that way we can continue working on what we've been doing. That's a lot of work. The group meets every week, so it's not like there's a long wait period that happens. And then Dr. Pliska and myself are always available to any HRIs if there's other issues that comes up in between the weekly meetings.
So Alex, I'm going to take that as a motion. Is that fair for approval?
That's
of this
fine.
document?
I move to approve the charter.
Okay. Do you have a second?
Second.
Second from Dr. Farmer. Any further discussion? Hearing none, all in favor of approving this document? The Data
Aye.
Management and Governance Committee?
Aye.
Signify by saying aye.
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 Okay. Any that are opposed, signify by saying nay. Is there anyone that's abstaining? Okay, so let the record show the unanimous approval of the consortium for this document. All right.
Yay.
Very good.
Very good, Alex.
So has Dr. Williams been able to join us yet? I think it's still another 20 minutes before she can join us. And
since she's not available, David, I do have one piece on the data manager that she asked me to provide the group with an update on if she's not available. So can I just go ahead and do that?
on the data manager?
Yes.
So this is germane to the last conversation, right?
Correct.
Or no, it's germane to the previous
The
conversation.
cost.
So I think you
It
can go
germanes
ahead.
to the cost, right?
Oh, to the cost. Okay.
Yes.
Well, okay. Why don't you go ahead and share that information?
So the update on that is we are looking into hiring a data manager that will work with every HRIs and our vendors like Track to help manage the various data flows, where the databases are, et cetera, as a resource. So the current status is that we've received a number of resumes, very outstanding resumes. They have narrowed it down to 2 candidates and have gone through the first set of interviews with Baylor and the Kosh folks. Those 2 candidates are being advanced to a second level of interviews with the data governance group, which is chaired by myself and Dr. Pliska, and of course representative from all of the HRIs. And so hopefully we'll identify and make an offer soon to this individual. So that's the current status update.
Very good. All right. Sarah, I think your hand's up from previous comment. Is that correct? Sarah, Dr. Martin? Okay, very good. All right. Well, there's one other maybe piece of business that we can do, and then we may take a little break and then and then come back. Actually, why don't we just go ahead and take a break, and then Dr. Williams will be here, and we can have the update on the cost at that time, and then finish up the other items. Does that sound reasonable to everybody? Okay. So why don't we break and start again right at noon? Okay. So I'll see everyone at noon. Thank you. We will start in 2 minutes, right at noon. I plan to start. Thanks. All right, it is noon. Let me do a quick check to see if Dr. Laura Williams, has she been able to join us yet?
I don't see her on here yet.
Okay. So why don't we then, there's one other item of business I need to do while I make sure we have a quorum, and then we can go back to Dr. Williams. So I'm going to do a quick jump and jump back to number 9. And so it's a little bit of a background here. In our bylaws, the presiding officer has to be selected every 2 years. I currently serve as presiding officer, but it's time to have that election. I am going to turn the podium over to Luann Southern and make sure that we follow our bylaws in the selection of the presiding officer. So Luann, I'll hand it over to you. Thanks.
Thank you, Dr. Lakey. As we mentioned at the June meeting, I requested that any executive committee member that would like to nominate someone to serve in this capacity for the next 2 years, do so. And I did receive from 14 of you a request that Dr. Lakey's term be renewed. I had no other nominations, but I would like to call out to each of you. If any of you have anyone you would like to nominate, please do so now.
Can't imagine it.
Okay. Hearing none, I would like to request that I call for a motion to approve.
So moved. Second.
Second.
Okay, well, that was quick.
Who are we approving? Congratulations, David.
Congrats. Well, thank you. It's a privilege to be able to work with all of you. It really is for me. So thanks for all the work you're doing, and I look forward to another 2 years of moving these projects forward. So thank you for the opportunity.
If I might interject, I heard a
Yes.
lot of motions, but no official vote.
Yeah. So let me take those comments back and you can have the vote.
Aye.
Oh, Luann, do you want to
Luann,
call
you
for a
have to
vote?
call.
Yes,
for a vote.
I can call for a vote. Let me just go through here real quick. And I'm going to ask for each individual to vote or abstain. And so here we go. Dr. Goodman,
I vote in favor of Dr. Lakey.
Dr. Williams, oh, there she is. Dr. Williams.
I approve. Let's go for it.
Dr. Harper,
I approve.
Dr. Wakefield,
Yes, I approve.
Dr. Trevino,
Yes, I support Dr. Lakey continuing.
Dr. Martin.
Yes, I'm glad he didn't abandon us for President Biden. He can handle us both.
Dr. Podewils.
I approve.
Dr. Farmer.
I approve.
Dr. Nemiroff.
With enthusiasm.
I believe Dr. Strakowski may have had to leave early. Is that correct? Okay.
Yeah.
Dr. Wagner.
Approve.
Dr. Vo.
Okay. Yes.
Dr. Bobitrode.
Just okay.
Dr. Bobitrode.
I approve.
Dr. Blader.
Well, I would have amended the motion to stipulate that Dr. Lakey place a bond, so he can't just abandon us. But under the circumstances, I vote to approve.
Dr. Escamilla.
Approve.
Mr. Patriarca. Dr. Bryant.
Approve.
Ms. Nichols.
I approve.
Dr. Taminga.
I approve with pleasure.
Dr. Ibrahim. Ms. Gaines.
Absolutely, I approve.
Dr. Keller. Dr. Martinez.
I approve enthusiastically.
Ms. Castle.
Total support.
And Dr. Borges. Okay, thank you, everyone.
Yeah, again, thank you all for that support. It really is a privilege for me to be able to work with you and again, see these programs develop. So with that, why don't we go then to an earlier part of the agenda to number 3, to discuss, consider, and approve information provided by Baylor College of Medicine and the role of the COSH related to the Child Psychiatric Access Network. Dr. Williams, it's good to see you here. And let me turn the podium over to you.
Okay. Hello, everybody. Sorry. I had some people ask me whether I have a good reason for not being here this morning, and I feel like I have a pretty good one. We're actually in the 3rd day of our statewide training for CPAN. We've had a really great turnout. We've actually, this year, we're really trying to make sure that we have enough voices from our pediatric and family medicine docs across the state. So they are actually helping inform our training. And so each of these 3 days we have 36 volunteers across the state of Texas who are coming in to help us see how we're running our program and give us hopefully constructive and good feedback to make the product even better. So we're having a really great day today, and I'm pulled out while they're doing lunch to kind of talk to you. And I think what you had asked for, Dr. Lakey, was the dashboard is what you wanted to see to review the state numbers for CPAN. Is that correct?
Actually, Dr. Williams, it is to go over the CPAN metrics. That is all that is on the agenda for today.
Right. So that's what I said. I'll pull up the dashboard. It just shows the state metrics. That's what we're looking for. Yes. Okay.
And Laura, I think there's actually a document that we were supposed to look at,
yes.
right? The proposed CPAN metrics procedure.
Oh, are you talking about the for counting for the denominator?
Yes. Yes.
Okay. Sorry, I'm doing too many things. So yes.
Okay.
So one thing I want to say, hopefully people have reviewed the document. We had several conversations within the actual CPAN team across Texas itself. We also had conversations with the data governance committee that Dr. Pliskas and Vo chair. And then we also had some additional conversation with other key stakeholders to really try to get to how can we have an accurate number when it comes to the providers in the state of Texas who are helping pediatric patients. And so we went through a number of different strategies, looking at which one may end up, we think, being the better strategy. And also the internal and external evaluation teams were very instrumental in helping us think through this issue. So that the document that you see today is really trying to help us within this next biennium have what we would call a number of total primary care physicians in the state who are helping young people. And that number, may change obviously from time to time, but we feel like it's been vetted and is a stable enough number that we can start to call it the denominator. So in order to do that, we looked at a couple different ways that different organizations say how many PCPs are in Texas. And even when you look at those other organizations, they still actually go back to what they kind of see their source of truth is that it's the Texas board. So what we've decided to potentially outline here is that we would have this next biennium, the evaluation teams would help us with this process, but that we would get the active list of providers in the state of Texas who are pediatricians and family physicians who are active in the state, download that list and distribute that list to all of the hubs so that they can see the PCPs in their counties, and that we would start using that as our base list to then start comparing it to the list we already have, but also to start helping us clarify as we're calling these providers to work to enroll and engage them, that we see truly how many of them are truly seeing young people in a primary care capacity and could potentially be enrolled. And then we also want to have a much better process that is statewide and it's consistent across all the hubs, that if a primary care physician declines to participate in enrollment, that we have a consistent way that we're gathering that information so that we report that number out as well. And so we're really hoping to rely on Molly's team as well as the external evaluation team to help us vet that so that we can sort of say, yes, this is where we can say is our reliable denominator. So questions?
Move to approve.
I have a motion by Dr. Wakefield. Is there a second?
Second, Potter Wills.
Second. Any further discussion? Hearing none, all in favor of approving this procedure for CPAN?
Aye.
Signify by saying aye.
Aye.
Aye. David, just a quick question to Laurel. Laurel, are you able to capture from the metric standpoint as I looked at the document, but I was just wondering, are you also able to capture like race, ethnicity, but also maybe geographic distribution?
So yes, we can, and that's a good thing, actually a great point to bring up. So when we get that list from the state, what it tells us initially is just that person's name, their specialty, and where their county, where they say where their county is. But when we make that phone call, if they choose to enroll, we will get that information because they will be given a survey to sort of say, what do you know about CPAN? So we have that initial survey. But for providers that don't choose to enroll, who say, no, I decline, we don't have a way right now to capture that sort of information. We would still just know that what county they're in. Gotcha. So that would be something for us to maybe think through, because that's true. We wouldn't know that those types of pieces of information at that point.
I'm just thinking strategically in the future of identifying maybe gaps as we start to identify them geographically, but also from a racial and ethnicity standpoint, and possibly if at all, if anyone's bicultural or multilingual, but just thinking about our future and what we could actually do with some of that data and recommendations we can make when we're thinking about workforce, since it's such a important factor for us.
No, I think that's really important. We had a lot of conversations around the survey and the length of the survey, and hopefully wanting physicians to complete it and not feeling that it was too long or offending in any way. But we really didn't have a thought, had not thought through the idea of what about the people who are saying no. So that's something for, I don't know if Molly's able to stay on or not, but I'll definitely bring it up at the data governance meeting next Tuesday. Now we have two new agenda items next Tuesday.
Glad I could help out. Appreciate it, Laurel. Thank you.
Sure, I will. We'll look into it. Thank you.
Laurel, as a practical matter, what we found is that it's not so much people actively declining, but utter non-response, and how we're going. And so what will be, this is a discussion for another day, but we are going to have to come up with a unified approach to, well, what's your due diligence? How many and what types of contacts and outreach does one undertake with before concluding that we've done all that we can and it's a true non-responder?
I think that's appropriate. And actually, one of the things we've been doing in these last 3 days of training, Dr. Blader, is really trying to help us understand what might get somebody from a no to a yes. I think we still do need to answer that question, though. If there's just never a response, when do we stop bugging them?
A lot of it, frankly, has to do with organizational aspects with it, because there are many instances where the physician or other providers don't even know that we've been trying to reach them, because we're dealing with front office staff or emails or other things, and somehow this does not grab someone's attention quite as much as, well, so-and-so called from Children's Hospital X, we just admitted your patient for sepsis, and that's going to be up there. And somehow our outreach so far hasn't, at least in the eyes of much of the office staff, because then we've had the experience multiple times where someone who wasn't even aware that we've been trying to enroll them somehow gets the idea to call us, or someone mentions and says, how come I never heard from you guys? So I could enroll. Well, we've been trying. So
yes, we've told the pediatricians and family docs the last 3 days that your office staff has been awesome. They've been a wall and they've been protecting you, but they've also been protecting you for something that might actually help you. So we are hoping we're going to get some additional strategies. And I know that Dr. Lakey's team is also looking into some additional ways to kind of help with that outreach. And so I know they're working on some processes there too.
Wonderful. Thank you.
Dr. Trivedi, I see your hand.
So Laurel, fantastic resource. You know, what you're calling your denominator is that group of primary care physicians and pediatricians who are now agreeing to at least pay attention or interested in mental health. So that brings up an issue that you may want to, or an opportunity that maybe we're thinking about depending on the level of consent you're getting. Because right now we are still going to clinical systems to provide services. But there, you can imagine, and all of us see this from real people in the community who call us and say, where can I go? And your denominator could become that network, so that if anybody, human being in Texas, wants to find out, where should I take my 16-year-old? They can go there and go to Dr. Smith because they will see and they're interested, but not go to Dr. Jones because they are not part of it, and or whatever they can decide. So that's a big service that this can provide. So possibly worth thinking about.
No, I think it's very much worth thinking about. I agree.
All right. So we had a motion and we had a second, but we started a vote, but we cut that short. Is there any other discussion before we have the final vote? Okay. Hearing none, again, I'll call the question. All in favor of approving the CPAN metrics procedure document, signify by saying aye.
Aye.
Aye. Aye.
Okay. All opposed, say nay. Is there anyone that's abstaining? Hearing none, it was approved with a unanimous vote. Okay. I think with that, Luann, please correct me, you and Lachelle, I think we have hit everything that we were supposed to do today in this meeting. Again, the main purpose was to get a budget done, and we have that approved, and we'll be able to send you the information you need in order to go to your Board of Regents. Luann, anything from you?
No, that's it. Thank you, everyone.
All right. Very good. Well, thank you all. And again, you'll get information from us and some requests from us as we try to figure out how we position the work that you're doing well in front of the legislature for these new funds that will be available to the state. And so please look for emails from Luann and our team. But again, we want to make sure we have a organized process, not to get in the way of what your institutions are doing, but a way to try to, again, elevate these issues as we move forward. With that, hope you have a great weekend, and And I'll see you back in, I guess in September, I think is our next meeting. So thank you all.
Thank
Bye.
you,
Thank
David.
you.
Appreciate
Thank
it.
you.
Bye, David.
Bye.
Congratulations.
Thanks.
Dr. Lakey, Dr. Tominga put in a note that she was stepping away and she would return at 1. You may want to reach out and let her know the meeting has ended.
Yep. Okay. Thank you.